Hello, I'm Dr. Aaron McMichael with the OSCA's Opioid Task Force. This group was recently formed to coordinate resources, intensify our efforts, and amplify our voices, focused solely on helping get through this opioid epidemic. There are a lot of exciting opportunities for you to help your community, but first, we want to make you an opioid epidemic chiropractic expert. We want you to be comfortable and confident wherever you're speaking, whoever you're speaking with. You should be the authority on this topic. So thank you for getting involved and taking the time to learn today. Let's go ahead and get started. We'll start by making sure you're familiar with opioid basics today. Then we'll move on to the actual epidemic itself. It's important you can tell that story of how the epidemic occurred and know some of the important statistics to go along with it. You'll learn everything you need to know to speak confidently on the subject and how chiropractic provides an important piece of the solution, but we'll also give you some more information as well if you want to find some other sources to learn even more in depth. And lastly, we'll talk about some exciting opportunities and how you can take action in your community. So first, the basics. What's the difference between opioids and opiates? Well, traditionally the term opiates referred to drugs naturally derived from opium poppies. Opioids was the term for synthetic versions produced of these drugs. Now, these days the terms are pretty much used interchangeably. I'd recommend keep it simple, go with opioids. That's what most people are doing. Now, there are all kinds of opioids available at this point. Here's a list of some of the medications out there. They all essentially act in the same way, working on opioid receptors in the brain and other parts of the body. Opioids suppress pain as well as inducing sensations of pleasure and euphoria, and at the same time, they trigger memory centers. So they're not just making you feel good, they're teaching you that this makes you feel good. So you want to keep coming back for more and more. Opioids activate receptors in the brainstem as well that can depress respiration and inhibit coughing. So that's why they're commonly used in cough suppressants. You may have noticed the FDA increasing warnings over the past year about using cough suppressants for children due to the breathing problems. Some children noticed depressing their breathing so much that they died from over-the-counter cough suppressants. Now, other receptors, when activated, cause slowing of the GI system, slow down that motility, which leads to another common side effect of opioids, opioid-induced constipation. So that kind of gives you the basics on opioids and how they interact with the body. This is a very important statistic to familiarize yourself with. This has been reported all over the place. You'll see this in the newspaper and the media. 80% of heroin addicts start with a reliance on prescribed pain medications, from a study in the New England Journal of Medicine. Now, there's one caveat with this to make sure you understand. Not the entire 80% were personally prescribed those pain pills. Some of them got them from friends, maybe took them out of the family medicine cabinet, got them in other ways. So they were not personally prescribed to them. So we can't go around saying 80% started with opioids that were prescribed to them, but we can say 80% started with a reliance on prescribed pain medications. Most have no idea those specific details of the study, but ultimately that just supports the need to keep these out of the whole entire house due to the risk of not just the person they're prescribed to, but others around them. Once addiction to pain pills started, then heroin dealers took advantage. They went to those areas where they saw high prescription rates. And this poster is available as a graphic that you can use at your clinic or events as well. We make that available to you. So here's a graph going back to 1999 through about 2014, looking specifically at Ohio, drug overdose deaths, And you can see the increase with most of that being caused from some type of opioids. Ohio has been considered ground zero because they've been number one in overdose deaths. Essentially, these people get hooked, that tolerance builds, so they want more for the same effect and more for the same effect. But if they stop, if they quit, their tolerance quickly starts reducing again. So their desire does not reduce now that their brain has been trained to keep wanting those opioids, but the tolerance does. At that point where they can no longer stay away and they go back for more, if they go for that same high dose that they once took, at this point they could end up dead because their body no longer has that same tolerance. So you hear stories about people who went through addiction, recovery, and then they went back and the next day tried the opioids again and they were found dead. This poster has more recent statistics for the past few years, and again, this is available to use at your clinic or wherever you'd like. You can see we're not getting any better with this problem. And 2017 isn't expected to be a great year either. That number has been going up by more every year. We are not solving this problem. On the left, there's a video link at the bottom. That's for a nice video that was done by the state a few years back as they were starting to take action, shut down pill mills, do a number of things. It has some good statistics in it. Check it out when you get a chance. It's important to recognize there are a few specific patient populations at greater risk of addiction and overdose death when it comes to the opioids. Of course, a history of addiction, that's definitely going to lead to increased risk. Also, mental health disorders, that's pretty straightforward. One other group you may not have heard of, though, those with renal and hepatic disorders, but that makes sense. They can't clear the opioids as well from their system, so it's easier for them to overdose on them. Military veterans and injured workers are also significantly more likely to die from a drug overdose. And in our region, when we've been talking at events on this epidemic and getting education out there, this is a point we often hit, that we need to do better for our veterans, we need to do better for our injured workers. This shows you a few more stats specifically related to the injured workers. 3 times more likely to die from drug overdose compared to the average Ohioan, which is already a high rate compared to others around this country. But it makes sense. When you look at the BWC system, the VA system, they prescribe opioids like candy. I just saw a veteran the other day that came in as a new patient, and she was tired of being given opioids for every single painful problem she had. It's just, here, take this, get back to the field. Or for the worker, here, take this, get back to work. Imagine what we could do just for veterans and injured workers if we helped them avoid these medications. And then think about the employers themselves. If they really want a drug-free workplace and cost-effective care that's going to give them healthy, productive workers, we could save them all kinds of money, improve their productivity, but what are they guiding patients towards? What are they guiding their workers towards? They send them to the OCMED centers that use the drugs. Their insurance provides better coverage of medication than non-drug treatment, so it sends them through drugs. Employers want a drug-free workplace, but they're providing insurance options to their employees that send them to the drugs. They don't even realize what's going on. So now that we've taken a look at the opioid epidemic and have some of that background, we're going to dive into a little bit more detail on the origins of how it really started. And I highly want to recommend Dreamland, a book written by Sam Quinones. Takes a really good look, well written, very story-like, so it's an easy read, keeps you entertained, but it covers a lot of detail on the different factors that came into play. A lot of focus on Portsmouth, Ohio, which has been called the pill mill capital, and that pill mill business model. spread out from that region to other places around the country as well. It covers the history of pain management treatment and how that was essentially forced to transform to just purely medication because of how insurers chose to cover different treatments or not cover alternative treatments. And then, of course, it tells the story of how heroin kind of played a role and got connected into this whole mess with the opioids as well. So if you get a chance, it's highly recommended. You could also get it from a website like Audible, where you can listen and get the audio version. So looking at the origins of this epidemic, there are a few primary factors that really caused this to happen. One, doctors were told pain was being undertreated, and new mandates, new standards came out that pain must now be considered the fifth vital sign. So it needs to be assessed at every patient encounter and treated when it's present, even if it has nothing to do with what the patient came in for that day. At the same time, doctors were then evaluated with patient satisfaction scores, and part of that was measuring how well doctors addressed the pain that they complained of. So increased pressures on doctors to respond to pain when noted by patients. Another factor, Purdue, they came out with their brand new and improved OxyContin medication with a special slow-release formula that they touted as non-addictive, essentially, and therefore great for any chronic pain. Not just terminal illness anymore, not just cancer anymore, great for any chronic pain you can think of. And then you combine those factors with the lack of training for most medical doctors when it comes to pain, addiction, neuromusculoskeletal conditions. Unless they received further training in pain management, orthopedics, something along those lines, Purdue especially realized they wanted to go after the primary care doctors, the family physicians who did not have much training in pain management but saw cases multiple times a day, every day. And they gave them an easy tool to meet the new standards that they were under pressure to follow. This quote is from the recent U.S. drug czar. Physicians get little to no training related to addiction in general, but particularly around opioid prescriptions. Over the past year, however, you hear more physicians admitting we are part of the problem. Not all physicians, but definitely more and more. When you're not trained well, what do? You listen to the experts, right? When you look at most of the 20th century, physicians were largely reluctant to use opioids for more than cancer or other terminal diseases. They'd seen the potential addiction when codeine was used, morphine, heroin, back when those were considered good medications out there. So they changed their approach and avoided those for the most part. But then came along Purdue with its newer medications and more experts saying we're under-treating pain. And a lot of these experts cited the same thing. They called it a landmark study published in the New England Journal of Medicine that found there is only 1% opioid addiction rate. Very low risk of addiction with these opioids. This was nothing like a landmark study. It was no more than a 5-sentence letter to the editor, published in 1980, and a doctor had written this as an observation he found looking over hospital data where he worked for those patients treated in the hospital with controlled doses of opioids. Now compare this to more recent studies from the CDC, where they looked at non-cancer patients, and those who had at least 1 day of opioid therapy, 6% were still taking them a year later. Of those who had about a month, 31 days taking opioids, almost a third of them were still taking them 1 year later. Another study from the New England Journal of Medicine said iatrogenic or physician-induced opioid addiction may be as high as 26%. Could certainly be higher than that, but we now know it's far beyond that 1% that's been cited over and over again. One other important point to make is while doctors were being educated from these experts, they were also told there's no maximum dosage. And if a patient comes back and says they need a higher dose, that's not a sign of addiction because these are low risk of addiction. That's a sign that the patient's still being undertreated, so up the dose. If they come back the following month and say they still need a higher dose, they're still being undertreated. So go with the patient and up that dose. There is no maximum. Now this quote's from the book Dreamland that I mentioned earlier. It talks about a doctor in Ohio who was one of the first to recognize the opioid issues. And he ran a data analysis looking at some of Ohio's data. He found a 0.979 correlation, nearly perfect, between prescription pills dispensed and the number of overdose deaths from opioids, which the book goes to say this was almost as if the charts were saying that dispensing prescription painkillers was the same thing as people dying. And as it shows here, it said Ohio could all but predict one overdose death for roughly every 2 months worth of prescription opiates dispensed. So we know with research, correlation does not prove causation, but that is a very strong correlation showing the relationship between prescriptions and deaths. One last point to make when it comes to those factors that contributed to the epidemic. We have to acknowledge insurers. They absolutely played a key role in producing this epidemic. You look at managed care plans and they gradually cut those services for anything other than medications, essentially, when it came to pain management. It used to be somewhat of a more comprehensive approach, but not once managed care took over. Does that sound familiar to anyone? Have you seen more restrictions for your care? Absolutely. Higher copays, higher deductibles, more limitations on the number of visits. Compare that to the early stages of the epidemic when insurers were actually reducing copays on opioid medications to make it even cheaper for patients to fill prescriptions. So we can definitely include insurance plans in this problem as well. So you'd think at this point the data is pretty clear. Everyone knows better. It's been in all kinds of media out there. Doctors are turning to other treatment options instead of opioids, right? Well, not according to an NPR survey that was released earlier this year. Opioid pain pills are still the most commonly recommended treatment for back pain. 40% of those with back pain, the recommendation they received from their doctor was pain pills. 20% injections, 12% surgery. When you look at the research, if you've had 3 injections, you're highly likely to move on to surgery. Again, if you look at the research, if you've had surgery, you're highly likely to be on opioids after surgery. So all these patients are getting stuck in this cycle and ending up on opioids and sometimes worse. Now, locally, we're hearing that some medical doctors are starting to become afraid of prescribing the opioids. So instead of providing them themselves, they're just referring them for pain management. So now these patients are waiting 6 to 8 weeks for pain management to see the expert on prescribing opioids. We need a totally different approach. This poster with the graphic here is also available for you to use with your clinic or events or wherever you'd like. Now let's look at the responses to addressing this epidemic. Number 1, shutting down the pill mills. Absolutely needs to be done, but between shutting down pill mills, increasing regulation of opioid prescriptions, if you're cutting off supply, you're not addressing demand. You need to provide some type of alternative. Otherwise, they'll find an alternative, and that can often be heroin, getting something off the street. Increased availability of naloxone, overdose antidotes. We're seeing some stories of patients being revived multiple times because they continue to overdose. They don't go through any kind of addiction recovery treatment. They're just revived again and again. Obviously not fixing any problems here. increasing availability of drug rehab. We have to provide good addiction recovery services to these patients, and some facilities are doing that well. Other facilities are new versions of pill mills. We're seeing stories about some of these places opening up now that these addicts have to be treated for essentially the rest of their lives so they don't go back to the street. They provide their monthly dose of medication. They say it's not covered well with insurance, so you pay your $500 or so for the visit and you're covered for the month. Where are these patients getting $500 cash every month? They're selling some of these medications on the street because they have a good street value as well. Take some, sell some, keep the cycle going. They're increasing education for doctors and patients. They need to do far better when it comes to this. Prevention when it comes to a lot of the messages, hey kids, don't do drugs. Well, they need to tell them a whole lot more. How about telling them, ask your doctor not to give you drugs in the first place. Start with something else. Of course, doctors need to be educated on alternatives. There's been a lot of money from the federal government thrown at this, and we're going to see more and more thrown at it as well because it's such a huge problem. But this is where the money's going. At the same time, you've got drug companies fighting any kind of change. You think they're interested in seeing an end to this epidemic? They're making a whole lot of money off of it. They're lobbying against any new restrictions on opioids. They're saying, hey, we're getting new abuse deterrent opioids ready. Well, OxyContin was abuse deterrent. How well did that work? It didn't. At the same time, they're raising the cost of these antidotes and medications used to treat the addicts or to revive them from overdoses. They're raising the prices 95 to 500%. So they're seeing high demand. Hey, let's make more money. Pharma is marketing more drugs for the side effects of opioids, like opioid-induced constipation, very common. These side effects alone are a $1 billion market for drug companies. They do not want to see this end. So can you think of a better solution than what's being done already? Clearly what's being done is not working. How about we try something different? Well, we have some guidelines that tell us just what we can try, and it's very supportive of the approach we would want to take. So Ohio released acute pain guidelines about a year ago, and these guidelines specifically recommend chiropractic manipulation, acupuncture, nutrition, exercise, massage, wellness programs, a variety of non-drug treatment methods to be used first when patients experience musculoskeletal injuries. They also noted opioids are last, and in those cases where opioids may be necessary, they should only be an adjunct to these options being used first. So they should continue with non-drug treatment methods even if they may require some opioids. When you look at the Institute of Medicine report, the Federal Drug Administration guidelines, and the Center for Disease Control guidelines, all of them recommend that non-opioid and non-pharmacologic approaches be the first approaches in dealing with chronic pain. So we're seeing a variety of government agencies at the state and federal level backing non-drug pain treatments as a way to stop this epidemic. The American College of Physicians released updated back pain treatment guidelines. They again recommended non-drug treatment like chiropractic for acute and chronic pain before trying pain medications to avoid the risks of addiction, abuse, and other harmful side effects. If you haven't noticed the last couple years with the research, they're seeing higher risks with Tylenol, ibuprofen, NSAIDs, those most common medications that doctors start with first. And they're seeing when they're actually compared to placebos for back pain, they don't perform any better than the placebo. So these aren't as effective as long assumed, and they're riskier than long assumed, even with short-term use. So those should not be used first. Non-drug treatments like chiropractic should be used first. The FDA released an educational blueprint for all providers of any type treating patients with pain. Among their recommendations, they said these providers should be educated on chiropractic and acupuncture as options for pain treatment. There are new hospital standards mandating non-drug treatment. So the Joint Commission, which accredits most of the hospitals in the country so they can accept Medicare and Medicaid payments, they were blamed for being one of the groups that started the epidemic. They were the ones that were mandating hospitals assess and treat pain as a fifth vital sign for every encounter. Pain as a fifth vital sign, that idea is dead. They said no more, bad idea. The Joint Commission is now coming out with this new mandate that becomes effective January 1st of 2018. They're saying pain management standards for hospitals and clinics will now require education on and access to non-drug treatments, including chiropractic, acupuncture, and massage. So they need to make patients aware of these options and one way or another provide access to these options, whether it's in the hospital or referral to another provider in the area. The updated standards also recommend consideration of treatment risks, including dependency, addiction, and abuse. This is common sense to us, but too often doctors are not even considering the risks of the medications they're prescribing. Clearly, the support is increasing for the care we provide non-drug treatment options, and chiropractic is a leading alternative. So a lot of good things are starting to happen, but that's not all. There's more to it. We're seeing more integration of non-drug treatment in medical facilities. Maybe you're not aware, but the Cleveland Clinic, even a few years back, they published a spine care path that recommends their first-line approach be chiropractic manipulation. The only other options were education with the patient or potentially, ibuprofen, something like that to start with. Now we know better than that. But they said first 4 weeks, chiropractic manipulation as a first-line treatment. If it doesn't work after 4 weeks, give it another go for another 4 weeks. Or at that point, then you could try some other non-drug treatments like physical therapy. We're also seeing ERs look at how they can utilize alternatives to pain pills as well. Not just necessarily chiropractic, but looking at a variety of different options that they could use. Canada is dealing with the same problem we are. They're second to the U.S. when it comes to opioid abuse and addiction and all these problems. So we're also seeing them start to look at chiropractic as a good alternative. A letter came out from 37 state attorney generals that was sent to insurers across the country. They asked them for better coverage of non-drug treatment, specifically mentioned chiropractic and acupuncture as one of the ways to combat the opioid epidemic. So they get it. They're seeing that we are part of the solution. New Hampshire even passed a law requiring coverage of chiropractic and non-drug treatment options. So they're pushing it even harder in that state. The President's Commission on Combating Drug Addiction and the Opioid Crisis has also recognized our potential. They released a comprehensive, multifaceted plan that specifically included chiropractic. It said, although in some conditions, behavioral programs, acupuncture, chiropractic, etc., have been proven to reduce the use of opioids while providing effective pain management, current CMS reimbursement policies, as well as health insurance providers and other payers, create barriers to the adoption of these strategies. So their specific recommendation, the Commission recommends CMS review and modify rate-setting policies that discourage the use of non-opioid treatments for pain, that make alternative treatment options cost prohibitive. The Commission is saying Medicare, insurance payers, reduce your financial restrictions on non-drug treatment options. Very good news for us. Most of the support and good news has all happened within just the past year, and I can almost guarantee there's more to come in 2018. Support for our drug-free approach is growing, and the opioid epidemic is not going anywhere anytime soon. As you communicate this growing support, strategically it's important to recognize the spectrum of non-drug treatment options, but just as important to emphasize the role of the chiropractic physician for very practical reasons. One, we provide most of those options out there. And one of the most important effective options, manipulation. Beyond that, we're educated and licensed so we can diagnose, evaluate, determine what is appropriate, and treat or refer as needed. PTs can't do that. Massage therapists obviously can't do that. Our care is safe and effective, covered by most insurance plans. And we can complain about that. The coverage needs to be much better, but compare it to acupuncture, which isn't well covered. Compare it to massage therapy, which isn't well covered, among other things. Our care is cost effective. We know that from multiple studies. Based on the research, one of the best treatments at reducing pain and improving function. There are very few that do both of those. And we have high patient satisfaction rates from multiple studies. So these are some of the key points to emphasize when people are considering treatment. This is what they want to know. Now kind of wrapping up with just a few studies that support our approach. There was a big study out of New Hampshire where they looked at insurance claims for 33,000 adults with back pain and found that those who received chiropractic care used 57% less opioids. They also used 27% less high-risk drugs of any type, but that is a significant difference in reduction of opioid use. So we know that, but now we also have the research that backs that. Another study looking at large Medicare data sets found that geographic locations with more doctors of chiropractic providing more chiropractic care, which with Medicare is, of course, manipulation, that equated to fewer patients on opioids. I don't have the specific number, but it was a significant reduction in opioid use. And again, this wasn't just more manipulation equals less opioids. They also said in areas with more chiropractors, there are fewer opioids being used. This was published in JMPT by Dr. Weeks and Dr. Gertz. While our greatest focus is on primary prevention, avoiding those opioids in the first place, it's also important to acknowledge the role we can play for those who are already addicted. Addiction is now considered a chronic disease that requires a lifetime of treatment with high relapse rates. These patients need every helpful tool possible to avoid returning to the opioids, and we provide a very helpful tool that they should be using. This study looked at a 28-day residential chemical addiction treatment program, and what they did is compared the standard program to the program plus chiropractic to the program plus placebo. And they found a significant difference for those patients in the program, including chiropractic. They were almost twice as likely to complete the addiction treatment program if they had chiropractic care. That alone is very powerful in helping these patients get the care they need. Beyond that, they also found lower rates of depression, lower rates of anxiety, a number of other benefits that we would expect as well. Thank you for taking the time today to get up to speed on this important subject. Please contact one of our co-chairs of the task force, Dr. Pat or Dr. Deb. Let them know you've been through the presentation, you're ready to take action. One of the next best steps to take is start attending your local opioid task force meetings. Just about every area has a group. This is a great place to make connections. You'll run into people from the hospital, other provider types, addiction centers and specialists, people in local government or agencies, a variety of different leaders in your community that you want to be networking with. And we have educational brochures, posters, things you can be handing out, materials you can use. There are a lot of great opportunities to attract media attention. We need to tell our story. This is the piece that's getting missed. There's a lot of coverage of opioids, addiction, the epidemic, but little coverage of non-drug treatment options is the solution, even with all of this support behind us. There are opportunities to increase collaboration with hospitals, like was mentioned earlier, and increase collaboration with recovery centers, and so much more. What we're doing is lining up all these resources, tips in one place. So however you want to get involved, however your local team wants to get involved, you can start taking action in your community. Lastly, here are some of the references from the presentation today. If you're looking for any specific source of anything, go ahead and get in contact with us. We can provide you with most any information that you need on this subject. Thanks for listening. Have a great day and start taking action.